think some new folks joined us in the chat. If you'd like, feel free to share what part of the health equity landscape you work in or why you joined us today. It's always helpful.
All right, so got one more minute before it starts. I'm sorry, I didn't even know if it was shared already.
Yeah, we're open.
Oh, well, recording a minute or so early. So, just gonna give it about 10 more seconds and then I'll turn it over. All right, well, good afternoon, I think to most, or morning, I don't know where everybody's coming from. I am Brandon Gare with the National Minority Equality Forum. I am here to just to introduce it. Before we get right into the webinar featuring Shyrea and Dr. Puckrein, I want to go ahead and say that our summit is April 17th and 18th, and the registration will be online as early as next week. And then, but today is the final day to apply for the 40 under 40. So if you have any great candidates, encourage them to apply. I'll put the link in the chat to check. So without further ado, I'm going to turn it over to Shyrea and Dr. Puckrein to talk about for today's webinar.
Thank you, Brandon. I'm excited to be here, especially as a former 40 under 40, or I guess still a 40 under 40, I guess always once, and part of the inaugural class. So I would like to say a big thank you to NMQF for having me join today for a topic that I'm passionate about, health equity. But Dr. Puckrein not only has been a leader in this space, but he has certainly been a wealth of knowledge, a brain trust, but also a stakeholder that has worked to advance solutions. So if you're joining us, hopefully you can share what your role is in the health equity landscape or why you joined, what makes you interested. And we're going to go ahead and get started. Again, I am Shyrea Thompson. I am the founder and principal of the IRIS Collaborative, and I also am proud to serve as a National Minority Equality Forum Advisory Board member. So I'm going to hand it over to Dr. Puckrein to just give greetings, and then we're going to get into some questions about what's changed in the health equity landscape and the policy pieces and where we're going in this movement. So Dr. Puckrein, we're going to have you start off with the hello this morning.
Good afternoon, everyone, and so glad to be here with you, Shyrea. Looking forward to our conversation. There's so much going on in the health equity space that I thought it would be a good time just to take a look at the landscape, try to understand where we are, what the future might hold for us, and how do we get from here to equity in our healthcare system. So looking forward to the conversation.
Really well said. And so when we started, when Brandon reached out, and I don't know how many of you know Dr. Puckrein's background, but he is literally a scholar and a historian as well. And so when you think about the landscape, there's such a great opportunity to learn from him about the movement. So I'm going to call him Gary moving forward because we are old friends in this space, and he knows that I certainly respect all that he brings to this work. But the first question, Gary, is what do you kind of define as the health equity movement, and how do you frame that?
You know, I think about that all the time. So, you know, we're always comfortable talking about police reform and that we need reformation in our how we do policing, and the same issue sort of really resides in healthcare. You know, from the historian's lens, the American healthcare system really gets started during World War II, when employers, because they couldn't raise wages because of price controls during the war, offered health insurance. And so that's how commercial health insurance gets started. And then in 1965, under the Johnson administration, the Medicare and Medicaid programs were born. But during those periods, you know, inequities were okay in American society. I know people don't want to talk about that too much these days, but structurally, segregation was okay. Structurally, by practice, it was okay. As the federal government moved into healthcare, some of the outward manifestations of the inequities went away. But what we began to do is use money as the decider. So in effect, what we do is we marginalize populations based on ability to pay. And so that system breeds inequities structurally. And so those of us who want to make sure that every person gets quality care understand that we have to reimagine that system. And I would just say this because I think it's incredibly important for us all to remember that healthcare has a purpose, right? Its purpose is to mitigate patient risk. We want to keep them out of the hospital. We want to keep them out of the emergency room. We want to keep them from disability. We want to keep them from dying, and we want to help them live high quality, long lives. That is the purpose of healthcare. And so when you introduce things like money as a discrimination factor, you necessarily will move certain populations out of quality, meaning you're not going to give them quality care because of the inability to pay. And that's the struggle, that we want to make sure that everyone who comes through the front door in our healthcare system gets the best quality care.
That is so right. And, when you talk about that, in our field, it's that whole no wrong door, right? Wherever we find you, whether you're in the community, at a clinic, an ED, emergency department, or emergency room, how are you getting that quality care? So in your opinion, what progress have we made? And I want to frame this because I think that if you do this work day in and day out, or you go to the conferences, oftentimes people feel it's daunting, right? And last year, we had a convening and a nurse stood up and shared, where is the opportunity for us to come and move the needle? Because we constantly are hearing about the problems. But what are the progress and what do we know is working that we can actually advance?
Certainly there have been progress. Obviously the Affordable Care Act changed the landscape because people got a healthcare card. You come into the American healthcare system and you have to show that insurance card because that defines what you get, who can give it to you, how long they can give it to you, and what it costs. So by enabling some people to have health insurance who did not have it prior to the Affordable Care was certainly a significant change. Now we could quarrel about whether they got the absolute quality care, and I would say they probably did not. But certainly that was a good beginning.
Or that it was the cost of a cell phone plan, right?
Exactly. I think what I would also say is there is general recognition now that our healthcare system has to be reimagined. I don't know anybody out there who thinks that this system can deliver quality care for the American community, for a diverse American community at that, right? So I don't think anybody would support that. And so at least we've reached some common recognition that we have to think about the future. And then, and then the question is, so how do we go about that? How do we give ourselves permission? And how do we begin to have, that conversation? At NMQF, I think the way we're going about it is facts on the ground. We want to do demonstration projects that show that you can deliver quality care to people while doing it in a way that's cost efficient, and challenge those who think that we have to ration healthcare. And so we are always looking for those opportunities to show that we don't have to ration, we can actually deliver quality care.
That's a whole mouthful, right? Moving from that mindset of scarcity, that there is enough care for all of us and quality care, exactly as you said. So when you think about these pieces, I always like to talk about this because I think when we first came on, you asked me how I was doing. And, we know that in this space, This work is not something you always just leave at home, right? And it's certainly not something that you leave at home when these communities are your community, when this community looks like you, when they're your mom, your dad, and your family members. So what's keeping you up at night in the health equity landscape? And if anyone in the chat wants to share what's keeping them up at night, we'd love to see as well. So I'm going to let Dr. Puckrein share.
I would start probably with the disinformation that is out there, some of it coming from responsible parties in our political systems, that it makes it really hard to help Americans make good healthcare decisions when you have responsible parties who are spreading disinformation. I think the other thing that I think about a lot is, so the fundamental principle of the legacy healthcare system right now is that we have unlimited demand for healthcare, but a limited capacity to meet that demand. And so we have to ration. And so the underlying principle of the legacy healthcare system is that healthcare has to be rationed, and the minute you ration, you have to pick winners and losers, right? Some people will get and some people won't. And you frequently do it in a way in which you're not explicit about how you're rationing. And the patients who end up getting ration care don't know they're getting it. There's no reporting out. It's like one of these social determinants of health that you don't measure, you just let it happen. I think at NMQF we would disagree with the premise that healthcare necessarily has to be rationed. Right now we're spending $4 trillion a year. Every American household is kicking in about $4 trillion a year for healthcare. By 2030, it's estimated to go up to $6 trillion. That's a whole lot of potatoes. And we think that given those dollars, we can be efficient and use those dollars very, very wisely to not just provide care in the moment, but to make the investments that we need to make to get our populations as healthy as possible. And I would say too, that the objective is really to control health outcomes. We have reached this place now where I think, again, giving ourselves permission, we can say, we can control diabetes. We can control cardiovascular disease. We're well on our way to controlling cancer. That's our future. That's what we're working towards. That's what the big fight is about. But we have these Luddites who want to ration, who want to tell us we can't, who want to slow up progress. And so that's what the health equity movement is about. It's about digging in and saying we can make the investments, because when we get to 2040 and 2050, we don't want to deal with diabetes anymore. We don't these chronic diseases to plague us. And so I think that's what the fight is about.
No, that's spot on. And I think years ago, when it was the anniversary of the Heckler Report, it was, how much more years do we have to do this? And now I'm like, I think that was almost, at this point, we're approaching a decade.
Yeah.
So how are we actually moving the needle in a substantive way? And I love that example because my background in cancer, and when you're looking at diseases like hypertension and diabetes, we know it can be done, right? We know that there are screenings that exist. We know that access has actually made a difference. And COVID has taught us a lot of that. But we did just receive a question that ties back to the Medicare, Medicaid point. So it's from Michael Garrett. Thank you. Although health equity is a clear and prioritized strategy for Medicare and Medicaid programs, employer-sponsored plans are still unaware of health disparities and health inequities, including a range of demographics such as race, ethnicity, sexual orientation, gender identity, etc. How do we address this?
I think the marketplace is starting to change. And what do I mean precisely about that? In my conversations with plans, some of them are starting to ask the question, can we pay for outcomes? So let's go back to the point, right? The point is, historically, the legacy system has been rationing care. So it wasn't really focused on paying for outcomes so much as managing financial risk. But now the conversation is starting to tilt slowly to a question of, so can we pay for outcomes? And I would push that outcomes conversation further to say, can we pay for patient risk mitigation? And the minute you move the system from rationing to taking a look at managing patient risk mitigation, you actually revolutionize the system, because now we're all involved in investing in each other's lives. That the marketplace now is about sustaining quality lives. That's a very, very different model from the legacy system. And the minute you do that, then you open the door to innovation, because now you're making investments with a purpose, as opposed to thinking that these investments are just going to drive more cost in the system, because you're operating from a very, very different purpose, a different landscape. So I think the plans get it. I think the pressures that are coming, if you look, for example, down at the state level, what you see is state legislators, particularly in those blue states where diverse populations reside, plans are being asked the question, what are the outcomes looking like for these patients? What's your responsibility? How can you help? And here I'm thinking about Medicaid programs, et cetera, that are under their supervision. And so I think that's the future. That's what we're leaning towards, is moving away from this financial risk mitigation to patient risk mitigation, where the healthcare system is now being designed to support our lives, as opposed to balancing checkbooks.
I love that. Exactly, right? Looking at well care and the people, not just the financial outcomes. We have another question that's building off of this one, so I'm going to go ahead and ask it now. Where do you see the opportunities between public health and the healthcare system?
So they, in my mind, they are the same in the future, right? Because when I think of public, I'll give you an example, and you can go Google it. There is no farmer that is raising any herd, be it chicken or cattle, that is not using a biometric device to help them understand the health of their herd. It would be malpractice for a farmer these days not to have a computer at his desk that is collecting all of the data about the health of his or her herd. We have that same capacity to deploy biometric devices and other tools. That's public health, right? You want to be able to look down at the zip code level and use hemoglobin A1C levels, for example, to understand how well are we managing diabetes for that population. So those metrics that we use in clinical care to help us understand the health of an individual patient, you can aggregate up at the population level and use them to manage population health. And then on top of that, you can add AI, so that now you're in the predictive space. You want to be able to predict the future of the population. That's where we're going with public health, and being able to go back to that whole idea of controlling health outcome and what we're investing in. That's our future. That's really, I think, the alignment between public health and clinical health, because essentially we're using familiar tools, but now taking them up to the population level.
What do you think we need to get there? I think collectively, we know so many times when EMR first rolled out, right? It was, oh, the doctors aren't going to like it. It's going to take time away, and you got to get the medical directors on board. So now we're in the AI front, right? And I know there's some pieces around equity and ethics and some other areas, but how are we actually going to do this together where we're not leaving anyone behind?
This is where the health equity movement comes into play, right? This is about will. This is about collective will and purpose for change. Not going to happen without it. And quite honestly, I think the patient advocacy voice is incredibly important here. I think that the healthcare system itself is so balkanized, and they're so in their lane that they need a catalytic agent for change. And I think the patient advocates are the ones that can bring that change, because guess what? As I look across patient advocacy groups, be it rare diseases or cardiovascular, kidney, you name it, they all want the same thing. They want better outcomes for patients. They want new technologies. They want to arrest the disease that confronts them. So I think a unified patient voice is really essential to this health equity movement to bring about the change.
I love that. I feel the same way. We were going to talk about that, what role has patient advocates played in advancing this? And I agree. And I've really enjoyed to see the evolution, right? Where the patient advocate used to just be called in to tell the story. I'm a former Hill staffer and you're a policy expert as well. And I think that this evolution as well, in putting emphasis on the patient voice and patient advocacy orgs, not just as, the storytellers, but we are the agitators driving this work as experts also. So I'm going to ask you, let's talk a little bit more about policy, because that was one of the pieces we were going to explore as well today. What policy changes do you think are impacting the health equity movement right now in the landscape?
So I want to give a very specific example of something that NMQF is working on that brings together policy and clinical and all of this. It's called our Cancer Stage Shifting Initiative, CSSI. So using African Americans as the example, if we aggregated all of the cancers that occur in the United States, African Americans have the highest incidence across all the cancers of any population in the country. And they get diagnosed late for cancer stages, 3 and 4, and their survival rates are poor. So what we've been looking at is a stage shifting initiative to move us from late stage diagnosis of cancer to early stage diagnosis of cancer. And so, we have a few screening tools, prostate, breast cancer, colorectal cancer, not being well used in our communities. And certainly we need to step up on that. And certainly NMQF is down at the community level, trying to make sure that those existing screenings are used. But also there are some new science out there, multi-cancer early detection screenings. They range from liquid biopsies all the way to platelet screenings. So where the science is right now is we can detect, literally right now, 50 cancers at one time with one blood draw, and we're able to diagnose patients at stage 1 and 2 before the outward manifestations, meaning tumors, have appeared. And so we can literally stage shift. Right now, we could do it if we wanted to pay for it. All of those high-risk communities where we see high risk of cancer and diagnose them at stage 1 and 2. That's revolutionary, right? I mean, that transforms cancer care, because rather than now treating people when the cancer is metastasized, we're treating them early in the disease. Unfortunately, our healthcare system doesn't want to pay for it right now, right? That's the fight, right? And this is about flying the plane and building the plane simultaneously. And so what NMQF is about is trying to put demonstration projects in communities to elevate the use of the screening, the existing screenings that are there, but also bringing these new MCEDs, these new multi-cancer early detection screening diagnostics into play, because we can save lives. But we also want to do it so that we are understanding how those patients who are now getting diagnosed at stage 1 and 2, how are they navigating through the system to make sure that they're getting quality care. We're also saying to our pharmaceutical and innovative friends, this is a great opportunity for you to learn about how to treat cancer at stage 1 and 2. Do your therapies work? Do you need new therapies? How do we do this? And so this is a learning experience collectively for us all that is not very much different from COVID, right? We had to learn on the fly with COVID. We should be learning on the fly because, at least in my mind, this is the beginning of the end of the war on cancer. That we now have technology, and if you think about it, I talked about the MSIs, but we can talk about CRISPR and all of the new science that's emerging because we're operating at the genomic level, and we can find new therapies.
Yeah.
Why are we not making that massive investment? Why are we not sprinting? I don't get it. And so NMQF, that's what we're thinking about. End-to-end cancer care using every tool and device that we have at hand to make sure that we stage shift, that we get rid of tumors in the same way that we turned HIV into just about a chronic disease these days. We can eliminate tumors in populations, and that's the science, and that's where we should be going to.
No, that's exciting. And I know that's part of the moonshot work that you're doing with NMQF as well. You mentioned COVID. And so I wanted to ask you, because I know there was so much emphasis on what we lost during that time, but we know in health equity, especially, there were some real gains. And we learned that if you could do it for COVID, you can do it, right, in this space. So are there any other outcomes from COVID policy-wise that you've seen that actually are making us move in a better direction in the health equity movement?
Well, I have to confess here. So I'm an old dog, right? I grew up.
You
before, yeah, old dog. So I grew up before the social media world, and before COVID. Didn't know anything about tweeting and TikTok and LinkedIn and all that. We had an opportunity to work with federally qualified health clinics during COVID. And one of the things in the conversation that I recognized was that these were trusted voices in community. Their boards were made up of community members. People in the community trusted them. But they had little capabilities to deal with this with social media and the disinformation, some of it deliberate, that was coming into minority communities. When I say minority, I'm talking about Asian Americans, Hispanic Americans, Native Americans, Black Americans. They're all feeling this. And I realized at that moment that we had to have a social media platform. We had to engage and begin to, because that's the way people were getting information. And so I've been really excited. We've got a fabulous social media team, and we're now fully engaged in the social media world. And we weren't there before, and we've done a lot in social media on flu and diabetes. The MSIs we talk about, and we've just launched, or about to launch anyway, a new essentially newsletter called For Your Health News that is being designed. It's like Google News or Apple News, except it's for the health equity movement. It is reporting out all of what's going on in the health equity space and health information. And so what it's doing is it's scanning about 80,000 periodicals a day and pulling out the key stories that are about the health of underserved populations, and then getting it out there. And I think everyone's going to be amazed at the amount of information that's being pushed out there that we just don't know because there's been no site there to aggregate it all. And so I'm very excited about that work. And it all came from our experiences in COVID, where we realized that if we were going to be engaged at the community level, we had to have a social media on.
So true, evolving with the times. And also, I think that's key, right? If you're talking about trusted voices and meeting people where they are, I always say live, work, play, and pray. Sometimes all of those things now with COVID are happening right online. So how are we making sure that we're bringing information that's accurate and represents the community and through those trusted voices? So that's excellent, Gary. I wanted to just ask before we head out of the policy section of our conversation, are there any policies past or present? Because I know we talked about COVID, but there's been some exciting things in the last couple of years as well that you feel are going to really take us to the next phase of health equity and advance the movement.
Sure. Obviously, the everything that everyone, at least here in Washington, talks about is IRA implementation, right? The last Congress put in place, among other things, pricing for prescription drugs, et cetera. How that gets rolled out is going to be incredibly important on the access front, because I think part of the presumption is, though it wasn't outly stated, but part of the presumption is that we're going to see greater access to medications. It's not just reducing the price of medications, but making sure that populations that did not have access before now have access. So I think us paying attention to that is incredibly important, because we want to make sure that we take advantage of that. We also, as I listen certainly to the folks in the rare disease community, we want to make sure that innovation is not hurt, because we have to innovate. There's only one way forward here, is through the innovation door, and so how do we balance that? And I think it also opens the door to a sort of fresh look at all of the costs and things that go into drug pricing, et cetera, et cetera. As I looked at the law, it was empowering CMS to take a deep dive into those numbers. So it's a great and important place for advocacy folks to pay attention to, because it's going to shape medicines and innovation for a number of years to go forward. So I think that's an incredible place to do. We also have to have a conversation about Medicaid. Because of I don't know if everyone knows that during the pandemic, a redetermination, meaning the way the Medicaid program works, depending on the state, I'm going to say roughly every 6 months, a person has to re-enroll in Medicaid. Remember now, Medicaid is it's means tested, meaning you have to have a certain level of poverty in order to stay in the Medicaid program. And so what happens in the Medicaid program is that say for example, you're in Medicaid and Christmas holiday comes up and you get a part-time job starting in October and it goes through December. You could get kicked off the Medicaid rolls because you got a job and you made money, and that's what redetermination is. It's constantly looking at did you qualify by being poor enough, right? And so during COVID epidemic, redetermination was stopped. People who were in Medicaid did not have to requalify. And the rough estimate is about 10 to 15 million people maintained the benefit of not having to re-enroll. So what the IRA did was, starting, I think it's in April, redetermination is going to kick back in. And so the potential of people losing healthcare is going to be there. There's some suggestion that they may be able to go into the marketplace and get health insurance. No certainty of that. But what's missed here is somewhere around 30% of African Americans and Hispanics are in the Medicaid program. So if you have redetermination where people are coming in and out of healthcare so that they lose access to continuous care, that is going to drive up inequity. That is going to drive up. And we frequently do not have that conversation about redetermination in the Medicaid program. But I think health equity folks need to pay attention to that because you have to have continuous access to healthcare. And so I think that's a big concern that's going to happen essentially for the rest of the year. I think redetermination has to be fully implemented by December 30th of this year. So we're concerned about that. And there are other places to look inside the system. I'm just giving you some examples of how the policies that are there have the potential to create inequities that we're not paying attention to and that we need to think carefully about.
No, that's spot on. And I love how you pointed out, right? We are creating a gap within that net that we know most certainly is going to further exacerbate outcomes. And if that's what we're trying to create these systems and this care for, how are we actually addressing that?
Yeah.
So I wanted to ask you, because you've been at this for decades, in the policy work landscape, what have you learned, or what do you feel you know for sure, or tips for those of us that are coming up, that new generation of the 40 under 40s and leaders in this space?
I would say this is a generational fight. This is not going to get cured tomorrow. If anybody thinks that we're going to wave a magic wand over this system and transform it, not going to happen. And, you know, it's like the civil rights movement. It's like any movement, a women's movement. It takes deep commitment of the people who are engaged. It takes intentionality and a sense of where you're going, and a commitment not to give in, to press the case. And I think that's really probably the most important takeaway that I would say to young people, is that you need to be working hard and getting ready to pass this on, as I am, to the next generation, because that really is the fight.
No, that is so true. And, you know, whenever you talk about that passing on the baton, I'm like, it's too soon, Gary. There's still more years left. But I think that that's so true, right? You know, if we look at other spaces, how are we building that pipeline of health equity leaders? And so Brandon did talk about this at the beginning. And now we have, I think, well over 280 40 under 40 leaders in health. And today, if you are just joining us, is the last day to nominate or to apply to be a 40 under 40 leader in health. I'll drop it in the chat. We've shared some other links. But I wanted to ask you, Gary, you know, when this kind of came together, what was your vision there? Was it some of that, you know, making sure that you could create a well where we could support each other and bring that mentorship in? You know, what's your vision for the next phase of the 40 under 40 program?
Well, I'm going to have to give credit to Brandon Garrett. He's the one who came to me to put together the 40 under 40 program, which I absolutely love. I've met some of the most bright, committed folks around the country who are doing extraordinary work. Again, I'm an old dog. I grew up in an age where not many minorities went to college, let alone to graduate school. I was probably in that first generation in the 1960s. Ford Foundation was the funder that opened the door to graduate school for certainly African Americans and Hispanics. That, again, you know, the system didn't permit that. But now I look at the amazing level of education and scholarship and capabilities that have manifest. You know, people, you know, forget that it's only since 1965, right? You know, a couple of 50 years that all of this stuff has occurred.
Yeah,
Which is an amazing amount of growth and transformation that has occurred, and more to come. And so I look at the 40 under 40. I'm so pleased and excited for them. What I often say to them is, I see the future in their eyes. I see where we're going, and it's exciting. So for those who have not applied, I encourage you to do it. It's a wonderful network of folks that you should know.
it is.
It's a deep network you should know, and we call on them often. So,
Yes, and for those of you that are listening, if you're looking for a deep network to draw from, I think that's the other thing. As an advisory board member, we are constantly talking about the well that we have as well within that group. I think our first class, the inaugural class that I was part of, I think we're class of 2016. So there's been so much of each one teach one and standing on the shoulders as well. There's another question that came through, I think going back to what we were just talking about, Gary, about the cost of medication. So I'm going to go ahead and ask that now. Do we need to also look at how the system helped reduce the cost of medications, but the deductibles increased?
So this goes back to the rationing mode, right? So the history goes something like this. Coming out of World War II, by the time we get to the 1970s, the US starts to face global competition. If you remember, Ford is now looking at Japanese cars coming in, and the consternation that was felt by the competition from Japan. And now you've got Korea, and you've got manufacturing competition from around the world. And so one of the things that industry leaders looked at was the cost of labor, and embedded in the cost of labor was healthcare, because health insurance, at least on the commercial side, is actually part of wages. It is, we don't tax it, so people think it may lose sight of the fact that it's wages, but if you're in business, you understand that to be the cost of labor. And so what happened was, in order to begin to control cost, industry partners started working with plans to manage their healthcare costs. And one of the places they looked at was prescription drugs, and you start to see formularies arising in the 1970s and 80s. And what those were doing was cost shifting. They were taking the cost of labor and shifting it back to the employee, right? Because it's part of the negotiation. So if I can shift some of that cost back over to you, all to the good. And so that's what we see. And when Medicaid and Medicare came in, I personally disagreed with this decision. Back in 2005, it was decided that Medicare Part D program should mirror what was going on in the commercial space. My sense of the difference was, in Medicare, it's a tax. That's how we got it through, right? You have to pay a Medicare tax. That's why the Supreme Court allowed it. And so in my mind, that's social insurance. That's insurance. You're not negotiating. The government is taxing you. And then they're turning around and picking winners and losers. They're saying, those people who can afford to pay that Part D premium or Part D cost should have access to the medications, or pay the co-insurance, particularly if you're looking at cancer care, where 20% could be $50,000, $20,000, $30,000, right? And so that burden then falls on the beneficiary, who in fact was taxed to be enrolled in the Medicare program. So I've always thought that the formulary piece of Medicare was inappropriate, and that we should push back on that, because if you think about it, those formularies, it doesn't matter your ability to pay. It doesn't look at disease intensity. It doesn't look at things like equity. None of that is considered in those formularies. And so, from a health equity standpoint, pure health equity, you'd have to say that that elevates risk for some patients because they don't have the capacity to meet the premiums. And I suspect that that's part of what IRA was trying to get at, but I think we have to think a little bit more deeper about that and what we're doing.
That was very comprehensive. And I think we just got a follow-up to this about the healthcare system. I'm going to ask about what do you think will be needed to address structural racism and other isms in a time of bills being brought up in the states that are suppressing the ability to talk about it, i.e. Stop Woke Act. And then it's a two-part question, in addition to the lack of diverse leaders in power in the healthcare system. So this is an interesting layer.
Yeah. All right.
Yes.
So let's have this. Let's have the conversation, as it were.
Yeah. Yeah.
Yeah. So we need to have the conversation. So historically, the economy was built around the exploitation of African American labor, right? That's what slavery was at the end of the day, right? Our bodies, our biology drove the economy, and the era of segregation sort of kept much of that going, and so it's an important thing for us to remember, because as we think about health equity, we're trying to address that, and I think right now where we are is, and this goes back to the conversation about paying for outcomes and paying for risk, right? Because when the value in the system becomes paying for good outcomes for patients, paying to mitigate patient risk, that value means that I no longer care who the patient is. I want to take care of their health because that's my return on investment. That's my business model, right? And the minute you make that transformation, you then begin to, I think, address some of the questions about race and structural racism, because if the patient has a bad outcome, you ain't getting paid.
And the isms don't matter at that point.
There is no ism. The ism is patientism. Let's make sure that every patient gets access to quality care. And so that's why it's so transformational when you think about paying for outcomes as opposed to paying for financial risk. Because when you're paying for financial risk, it sort of encourages the inequities. It encourages the isms and the differentiation of populations, because you now believe that my ability to get quality care is only possible if that group over there does not get quality care, right? I mean, that's the formulation, that we can't take care of everybody, and so we have to ration, and those people who don't get, we'll call them the other and think all kinds of stuff about them and get on our merry way. And so those part of our policy world, political world, who subscribe to that, they push it out there. But as we start to reimagine the healthcare system and move it and guess what will happen? When you start to pay for patient risk mitigation, the plans are now engaged, because guess what? I get paid, the doctors get engaged, because guess what? I get paid. I go to the pharmaceutical company and say, I need your best product, because if I can get this folk out of the hospital, keep them from disability, guess what? I'm making my numbers, and everybody is in the business of making sure that we're conserving long quality lives. That's a powerful economy. And I think in that economy, issues about race and otherness begin to get subordinated as we push forward to collectively manage health outcomes for everyone.
Yeah, that was really well outlined. I think this question may also be answered by the answer you just gave, but I'm still going to put it forth. It's, what are your thoughts about effective approaches and strategies to addressing intersectionality?
It is the same question, isn't it? You know, if you have a society where you're, I'm going to take us a little deeper. I'm going to take us to our social contract, right? When our political leaders, some of our political leaders, say America is based on an idea, the idea they're talking about is all men, including women, gender neutral, are created equally, and we're working together for life. Actually, the original language, preservation of life, that's what Jefferson actually wrote, preservation of life, liberty, and happiness. And that's our social contract. That's what we've all agreed that we're working on together collectively, right? And in that, we don't distinguish groups. We don't divide up the gross national product so that some have more and some have nothing. We don't divide up healthcare so that some people get quality healthcare, some people don't. And I think that reimagining brings us closer to the perfection of the American experiment, if you will, because it is fundamental. It is the idea of America that we're all in this together, trying to make sure that we conserve life, we enjoy life, and we can do it with liberty. I think that's the fundamental.
I think that was a bit of your historian meets health equity leader experience in there. I'm going to actually just let everyone know, if you're listening, we have a couple minutes left. And if you'd like to submit a question, you can. They've been great so far. And as we wait for any final ones to come in, I'm going to ask you, Gary, because I know you keep hinting at retiring. But in your, NMQF, was it 1998 was founded?
Yeah.
So that's 25 years, right?
Yeah.
This is a milestone year. What are you most proud of? Or when you look at little Gary with an I and you think about legacy, that's his daughter, for those of you listening. What are you most proud of in this space in the health equity movement? And what do you see is next?
I think in the immediate sense, I am so proud of the team of folks that work at National Minority Equality Forum. I really, I'm being very, very serious. They are incredible. I don't, I run my mouth, right? But they're the ones actually in community making it happen. And they're committed and they're skilled and it's just an amazing group of individuals. I think the other thing that I think a lot about is the handoff. When I first came to Washington, there was a guy named Carl Holman. He ran an organization called the Urban Coalition that many of you probably don't know of, but he was very much part of the civil rights establishment back then and was very much involved in a lot of the civil rights gains that were made in the 60s and 70s. When Carl Holman passed away, the Urban Coalition passed away. And I've always said to myself, my sense of success is I pass along an organization that continues the journey and continues the fight. And that to me would be success, that we have a next generation taking up the fight. Because, as I said, it's a generational fight. And so that would be my measurement.
Oh, I love that. And I think that you certainly continue to advance that goal. We know that National Minority Health Month is April. And for those of you that might not know, we have the annual Spring Health Brain Trust that takes place in April as well. But I love this fact that, you know, Gary, you've been in the trenches so long, you actually helped establish that month. So can you tell us a little bit about why was that important for those that don't know? And why do you think today it's still important that we actually have that observance and working to come together each spring here in DC for the Spring Health Brain Trust?
So when I came to Washington in the 1990s, the goal was Healthy People 2010. I think most folks probably don't know that, but the federal government said that it was going to eliminate health disparities in 10 years, right? And I was new to Washington, and I thought, well, if our government says they're going to eliminate it in 10 years, we all better get to work and get it done. And so made two commitments to that effort. One was to collect data. So NMQF started off collecting health data, which we've been doing for 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year, covering well over 100,000 different conditions. And so we use that data in all of the work that we do. And we partner with patient advocacy groups and health plans and pharmaceutical companies, you know, you name it. We're partnering with people to try to understand how do we literally improve outcomes down on the ground. And the other piece of that was a pacing event. We wanted to set a moment in time when we all came together and thought about health equity and an opportunity to bring about change. And April was that month. Now, there was some effort earlier on in the 1990s talking about health equity. I mean, talking about a health month for minority populations. And I would also say, again, the historian, Booker T. Washington started National Health Week back in 1915 at the same time that Carter G. Woodson started Black History Month. And so there was this historical legacy for, it was called Negro Health Week by Booker T. Washington. Great set of history. It got adopted by the federal government. Folks could go and check that out. There was a big initiative that lasted just about to the end of World War II, actually. And so, you know, understanding that history, we put together and got I guess it was the 104th Congress to recognize April as National Minority Health Month. It allowed the federal government, that resolution allowed the federal government to do programs in April. And we encourage everyone to pick up that theme because it creates a moment in time where we can have this conversation about health equity and the need to make sure that all populations have access to quality care.
That is so true. And you got a history lesson in, and also a Black History Month fact. I feel like you're a check on your historian energy. So before we go, I'm going to ask you, one, what's giving you hope in the health equity movement? Because we know this work can be daunting, but what do you think is giving you hope to continue before you retire on us?
I think the idea of eliminating inequities in healthcare has spread, and you can see it in legislative bodies. You can see it in policy. You can see it inside industry. You can see it in the grassroots campaign. You can see it in the rise of patient advocacy groups. It is clear. And also, you know, quite frankly, the browning of America, you know, is driving it as well. That as America becomes brown, the populations that didn't have health care before are not going to put up with it. And so they're going to put pressure on the system as well. And then finally, I think our science, I just marvel at, so back in the 1970s, there was a guy, Thomas McGowan, was a physician, and his position was that medicine did not improve longevity, that there was no evidence, a big debate. I don't think anybody can say that now. I think the science, we look at the science, we are turning what were once lethal diseases into chronic, if not, in fact, curing them. And so when you put all of those things together, people of diverse backgrounds are going to demand quality care, and the system is going to have to perform. I think if I was laser focused, what I would say to you is healthcare financing and delivery system is the problem. It's not the science, it's not clinical. It is, that's where the innovation really needs to be focused at right now. Healthcare financing system is completely and totally broken, and it breeds inequities, and we have to figure out what to do about that.
Well, I was going to ask you what was your call to action, but I feel like that clearly is it. So is there anything else you want to close us out with today as we look forward to advancing the next phase of the health equity landscape movement?
Well, first of all, a big thank you to you. I appreciate you, moderating this session, and a thank you to all of the folks who joined in. We reach out and hopefully we can join the collaboration and really reimagine a healthcare system that's worthy of the American people. I think that's really the goal.
Couldn't have said it better. Thank you, Gary. And I think as we all march forward this week into the weekend, let's take that with us, giving ourselves permission to reimagine the healthcare system for all Americans. Thank you so much.
Well, thank you.
It's been great.
Great.
Have a great afternoon, everyone.
Bye-bye.